So my name is Gemma, and I am welcoming you all to our final AYA Talk session of the year. This has been a really great four-part series, and we're really excited to finish it out with this presentation, A Healthy Dose of Self-Love and Addressing Body and Sexual Health After a Cancer Diagnosis. So this series is brought to you by the Inova Adolescent and Young Adult Program, in partnership with Inova Peterson Life with Cancer. And so our goal with these talks is to periodically provide guidance and education on real life and real talk for AYA patients with cancer. So some housekeeping before we get started. We're going to have about an hour and a half or so of content today, give or take. So kind of settle in, get comfy, stay for as long as you can. But please feel free to send any questions via the chat throughout the session. We might have to wait for most questions until the end, but there will be a Q&A portion. So if anything comes up as you're listening, feel free to use that chat function or the Q&A button at the bottom of your screen. We ask that you try to keep questions general and refrain from sharing too many specific personal information just because this is a recorded webinar. That does mean that we'll have the recording available for viewing on the Inova Peterson Life with Cancer YouTube page. And at the same time, we want to be mindful of your privacy. So something to keep in mind when asking questions. And then there will be a lot of great information shared today. So maybe a lot of information to process. Know that in a follow-up email, I will be sending out a copy of the slides so you can refer back on information shared. So without further ado, I want to introduce our two wonderful speakers. We have Lauren Broschak joining us, who is a licensed clinical social worker in the Virginia and DC area, an oncology certified social worker. Lauren earned her Master of Social Work degree from the University of Michigan, along with certificates in sex therapy and sex education from the university's Sexual Health Certificate program. She has extensive experience in oncology survivorship, coordination of sexual health programming, as well as individual and couples therapy at her private practice, Kind Root Counseling. Lauren served for 5 years as the co-chair of the AYA Special Interest Group with the Association of Oncology Social Work, and currently serves on the board of directors for After Cancer, a national nonprofit dedicated to advancing the standard of care by educating oncology providers on screenings for sexual health side effects. We are also joined by Kari Wheeler. Kari is a pediatric nurse practitioner specializing in adolescent and young adult oncology at the Pediatric Specialists of Virginia Center for Cancer and Blood Disorders at Inova Schar Cancer Institute in Northern Virginia. She received her Doctor of Nursing Practice in Acute Care Pediatrics with a Certificate of Teaching in Nursing and Health Profession at the University of Maryland School of Nursing. Kari has dedicated over 10 years to the field of pediatric hematology and oncology and is passionate about using her skills to improve outcomes for young people facing complex health challenges. All right. Thank you, Kari and Lauren, and I'll hand it over to you.
All right. Welcome, guys. I'm very excited to get started. I know you're going to hear, obviously, from a well-versed expert tonight in a lot of this, but I like to think that I have a little bit of information that I can share and some wealth of knowledge that I've learned along the way from my other AYA cancer patients. So I'm going to kind of get us moving. Okay, let's see if I can drive this boat. So first, we're going to start with just a general overview of kind of what we're going to go through today. So I'm going to kind of review some of the statistics around body image and sexual health identity in AYA cancer patients and kind of give you a sense of like why this really matters to this population. And then I'm going to go into a more thorough discussion on body image and its impact during cancer treatment and various different interventions you can use to help cope with some of the changes you might be experiencing throughout your cancer journey. And then Lauren's going to come in and use her expertise to talk about sexuality and the cancer experience. And then we'll kind of finish off with a Q&A. So to get started, we're going to talk about why this matters. So human beings have a natural desire for intimacy at some level. So whether this is with friends or with romantic relationships, this is really important to our population. And sexuality and intimacy really aren't life or death issues. They are actually very, really quality of life issues, especially for our AYA cancer patients. Sexual health is actually a key component of comprehensive care for AYAs and those surviving their cancers. And it really kind of encompasses a wide-ranging topics, including sexual orientation, gender identity, body image, sexual expression, relationships, pleasure, sexual function, sexually transmitted diseases and infections, sexual violence prevention, contraception, pregnancy, fertility, all of these things. And sexual health is actually a developmental task of adolescent and young adulthood. Those are the years that you are creating your sexual identity, you are establishing romantic and sexual relationships, and you're exploring sexual preferences and practices. The challenge of this is that when you're dealing with a cancer while also navigating these intense physical and social changes, this is really inherent to the young adulthood. So we're going through so many changes with a cancer diagnosis, but then you're also dealing with these developmental changes that you should be going through as well. So kind of like I said already, when we think about the context of relationship development through the ages, there's a lot of things that kind of happen. In your early young adulthood, you have very fluid relationships with friends and peers. A lot of people are exploring their gender identity, and there's a lot of sexual activity sometimes without standard commitment. And then when you move on into early adulthood, so when you're about 19 to 25, 26, that's when your relationships tend to increase in duration. The level of intimacy deepens. You might have one of your first real long-term relationships during this time period. Many people get in relationships with college peers and things like that. So that tends to change. And then often in early adulthood, you are already have very committed relationships. You've kind of explored a lot of things sexually, and intimacy is at a deeper level and a deeper concern at this time. And that's usually in that late early adulthood. So I want to kind of address that this tends to be a taboo topic amongst a lot of people and a lot of healthcare providers. It's really an under-acknowledged topic in general health as well as cancer care. And we know cancer really is that biological interruption. So there's different missed opportunities for you, including maybe not attending school. You have missed experiences among your peer group interactions. You might not have the same maturation speed as your peers because you have missed those interactions and or experiences. Oftentimes our AYA sex education at school, so they don't always get the fundamental knowledge and skills they might need. As well as many of my AYAs have some very overprotective parents who and they lack the distance, the independence, and things that help them kind of develop their own individual sexual identity. Adolescence is also a very time of change and development. There is often unmet needs related to contraception, body image, romantic relationships, and there's also very misunderstandings and misconceptions about how to prevent sexual infections and things like that. Oftentimes, you're learning from your peers about your sexual experiences and or not necessarily from qualified medical healthcare providers. There's also multiple factors that contribute to poorer sexual health in AYA's cancer. Usually just the physiological effects of cancer and cancer treatment. There's a disruption of typical sexual and psychosexual development. And then sexual related health issues may be exacerbated by poor communication, both by it's kind of hard to talk to your medical provider about this, but as well as providers aren't always as comfortable having these conversations. And then there's a lot of concerns about confidentiality. Are you going to tell my parents? Will they see things in my medical record if I'm getting specific tests done? These things make it really difficult. And it really requires a holistic approach to consider how we approach sexual health and wellness across the age span. I will say that sexual health and body image concerns are common. About 67% of patients do not recall conversations about sexuality with their oncology providers, even though about 79% felt it was actually important. And we know the data does indicate that AYAs are sexually active during treatment, with up to 70% actually not using effective protection during cancer treatment, including contraception, which for me as a healthcare provider can be a little scary, but I know it happens in the real world experiences of our AYAs. And then we know that negative changes in their body image can influence sexuality and self-esteem as they're going through cancer treatment. I'll talk a little bit more about all of that and what changes come. Um, but I also want to acknowledge that a majority of studies suggest that anywhere from 50 to, and this number is actually under on this slide, but anywhere from 50 to 80% of cancer survivors experience sexual dysfunction or sexual health related side effects as long-term effects of their cancer treatment. And these are really important to be able to acknowledge because they really do impact your quality of life and how you're moving forward in your cancer journey. And then it's also really important to acknowledge that sexual and gender minority individuals, so those who broadly identify as LGBTQ plus, are a diverse population that is actually underrepresented in AYA cancer research as well as sexual health research. And we as oncology providers are constantly not given enough education and or knowledge to be able to provide adequately for this population. It's coming, and there's a lot of training that even I have done as a new provider, but there's not enough for us right now. We need to be doing more to be able to support this population. So as I move forward, I want to just kind of show you what I like to show a lot of my AYAs, which is basically the biopsychosocial model of sexual health and cancer treatment. So this model does a good example of just showing you all of the different things that kind of can impact your sexual health through your cancer experience and your sexual health with or without cancer even. So there's a lot of different educational milestones, your identity, your diversity, and as well as your own autonomy that plays a part in this full picture, as well as what your body is doing biologically, what your relationships you have socially, your psychosocial background, and your mental health plays a part in this, as well as your interpersonal relationships and your influence from your family or your culture. All of these things really impact the whole sexual health and wellness of any individual, whether you have cancer or you do not have cancer. Okay, so saying this, I'm going to move into more of our body image discussion. So let's start with the big question. Why does this all feel so hard right now at this specific time in our life? And really, the simple answer is because you're an AYA with cancer. You're really in a unique and uniquely challenging stage of life. So like I said, this stage is from your mid-teens all the way through your 30s. And we think about AYA, it's that 15 to 39 population. And this is really the identity stage for you. So this is when you are actively building your life, you're figuring out who you are, but also what you stand for, who you want to be, who you want to date, what career you want to build. And let's be honest, our bodies are actually a huge part of this. How we look, how we dress, how we move through the world. It's our way of telling people that this is who I am as an individual. At the same time, you're in this social pressure cooker in a sense. This is the age of first dates, college, job interviews, starting families, finding your friend group. And then there's also this intense pressure and inherent kind of, I guess, attention to look the part, to look normal, to feel healthy and capable and attractive. Um, and then we're also dealing with all of this while we're scrolling through social media, which is basically a non-stop stream of curated and filtered and best day ever images. And it's a comparison trap on, and for any individual on a good day. But when you're dealing with hair loss, a new scar, a port, or fatigue that no one else can see, that comparison trap feels even more intense and unfair. So when cancer comes in and changes your body without your permission, it's not just a physical thing. It feels like it is directly attacking your identity and your place in the world. And it's okay to be feeling grief or anger or frustration about this. I want to be the first to tell you that those feelings are valid and you are not vain and you are not shallow from feeling those ways. This is a 100% completely normal reaction to a deeply unfair situation. So when we think about what the term body image means, a lot of people just think about it means appearance or what you see in the mirror. But it's really much more deeper than that. Body image is really made up of about two parts. First, it's what you think. It's about your thoughts and beliefs you hold about your body. My legs look weak. This scar is ugly. I love my hair. I'm not as strong as I was. Second, it's about how you feel. It's the emotions that come up when you think about your body. Do you feel pride in how you look? Do you feel shame? Are you comfortable in your own individual skin? Do you have any anxiety about specific parts of your body? Or maybe you're just feeling overall just disconnected from what you see in the mirror. Before cancer, your relationship with your body was already pretty complicated and something that you were trying to figure out. And we all have our issues with body image, but really, cancer changes this experience. Suddenly, this body that you have lived in your whole life might feel like it really has betrayed you in a way. It got sick, and it is a source often of pain or fear. And then the treatments that we use to save you all are also causing a lot of changes to your body. We have hair loss, weight changes, scars. This really does create a confusing and conflicting sense of who you are as an individual. You can be incredibly grateful for a body that is fighting very hard to survive and or has fought very hard to survive your cancer experience. And at the same time, also be angry or sad or feel totally disconnected because of what it's been through. The feeling of betrayal is the key, though. Your body might not do what used to want to do, but it does, and it doesn't look the same, and it doesn't might not have the same energy. And that shift in the relationship from one to trust to one of uncertainty and betrayal, that is the core behind body image struggles after cancer. So this talk isn't about learning to love your scars. It's about rebuilding a relationship from the ground up. In the next section, we're going to briefly kind of go through some of these other causes of body image change that makes this whole picture really so complex. Um, so it's important to name these things because sometimes we know that your specific worry is a known side effect, and that could be validating. So I broke this down into kind of two categories so that everybody can see, and both are equal in very many ways. These are the visible changes and the kind of invisible or hidden changes that anybody who's gone through cancer experience might not see. So when we think about the visible changes, we often see scars and amputations. Um, there are a lot of layman's people who say they're battle wounds, which makes it sound brave. But sometimes the scars can feel like an unwanted sign or a reminder that you don't look the same. Whether it's a surgical scar, a scar from a mastectomy, or even smaller scars from biopsies or points or port sites, these are permanent. As well as if you've had an amputation, it's a profound shift in how the world and how you see yourself reflected back in it. And it requires really an adjustment to what your new physical form might look like. There's also hair loss and or regrowth. This is actually one of the most immediate and visible public indicators of cancer treatment and one of the most distressing things for a lot of our AYAs. And hair is really deeply connected to your identity, your gender, attractiveness. For many of our AYAs, so losing it can feel like losing a piece of yourself. And the regrowth process can be very unpredictable. Some of my AYAs have lost their hair throughout all of their treatments. Some of them gain it back at different points and then they lose it again. It might be patchy or a different texture or color. And this overall lack of control really, and, and having something so public about you change is really isolating sometimes. And then there's all of the weight fluctuations between the chemotherapy, the steroids, the changes in activity level. That causes a lot of rapid shifts, whether you gain or lose weight. And we're also used to being physically active, that losing muscle mass can make us feel really weak. And then there's steroid-induced weight gain, especially in the face and the abdomen. Everybody talks about the moon face. And this is entirely sometimes outside of your control, regardless of diet or effort. And then these existing changes also can make your clothes not fit the way they do and make your body not feel like it's yours anymore. And while the visible changes are hard, there's often invisible changes that wear people down because they are a load that you carry that others actually can't see around you. So just functionality, this is a core issue for many of our AYAs. Your body may look fine from the outside, but the inside things have shifted. You can't walk as far as you're used to. The stamina you had is not the same. You might always feel exhausted. This feeling of being physically limited, of having a body that doesn't respond the way maybe your peers are doing in a healthy young body. Can cause a lot of feelings of being broken or unreliable. And then fertility and sexual health also fall into this category because there is experiences of fertility preservation or loss of fertility. That's a huge burden for a lot of AYAs who maybe not might not have been ready to think about their future that far in advance and or are in that phase but have lost their ability to have be a parent in the future. Similarly, changes in libido, dryness, and other related sexually health related side effects really can impact any intimate relationships and or confidence that you might gain from those experiences. There's also the medical devices like ports, ostomy bags, feeding tubes, all of those things, prosthetics, that really make it a complicated relationship with your clothes or your physical activities. And even when these are hidden, they're a constant physical reminder. People still kind of touch their chest when they're thinking about their ports in place, or they might kind of rub their legs knowing that the prosthetic is just there underneath their jeans. It makes it really hard when you're trying to hide these things because you worry about them being visible, having to explain them, or if you're having something like an ostomy bag, that it might leak or things like that. And then there's often the late term effects of treatment. So even after you're done with treatment, you finished everything, the changes in your body unfortunately don't stop. There's chronic fatigue, persistent pain, and these can be really invisible handcuffs to an individual who just wants to get going and back on their life again. They restrict your life and how you interact with the world, and they make you feel less capable even years out from where you've gone through treatment. Similarly, conditions like cancer-related neurocognitive changes, so that chemo brain or brain frog that we often hear about, is a very real set of symptoms that can profoundly impact a person's daily life. So it's not just about feeling tired, it's about those changes in memory and thinking and focus, and how do you adjust to those changes when you need to be doing various tasks for college or a job. That can make it really challenging. The take-home message of this really is if you feel like a different person in your body, that's okay because your body is different. But different doesn't mean it's any less. We're going to talk about later in this experience kind of how we rebuild that relationship with your body. So before we kind of discuss some interventions to cope with body image changes, I did want to kind of highlight just on social media and body image. Social media use is universal amongst the AYA population. Over 90% of teens are using YouTube, and about 60 to 70% are using TikTok. I'm sure that number is even higher now than from the research that I was looking at. And it's no surprising that it's popular because it has many facets, including synchronous and asynchronous communication, sharing of self-made content, personalized feeds, and targeted content and advertisement through automated algorithms. Um, but given the variability of social media, it's not surprising that there are many different effects for it. And the effects on a particular individual are really shaped by that person's circumstances. So, who that individual is, what are they currently experiencing in their daily life, and how they're choosing to use social media. We know this because we see all of the, I'm going to cloud magically has something appear on my algorithm. Those experiences and things are there. Social media, though, is really complex, especially in regard to social, physical, and mental health. There's really a dichotomy about it. So while it can promote a sense of community and closeness, it can also create a sense of exclusion and inadequacy and a pressure to fit in. Criticism of social media also includes that it can increase anxiety and augment drama that necessarily might not exist. For example, social media might really help a lot of my AYAs feel connected to their peers, especially during a cancer diagnosis. But I've often seen a lot of them become very distracted and often fall into the comparison of what their peers are doing while they're not doing these things. And it can lead to feelings of anxiety, depression, and isolation and FOMO or fear of missing out. Notably, when it comes to body image, 4 in 10 teenagers, so about 40%, report that the images they saw on social media caused them to worry about their body image. And I read this really unfortunate and kind of scary, in a little bit of a way, study that researchers who created false teen accounts on TikTok tracked their feeds. And within about 2.6 minutes of these having these TikTok feeds with these automated teen accounts, it led to suicide content and recommended eating disorder content within 8 minutes of establishing these accounts. They also determined that every 36 seconds, TikTok was recommending videos about body image and mental health to teens. Really, this study kind of illustrates that providing content based on a user's perceived preferences may not always be in the best interest of your mental health. I'm not saying all social media is bad. We are all very well vested in it. Myself, as a older AYA, is definitely had the experience of growing up with social media. And we've all heard these amazing stories of what it can do. And I'm a firm believer in utilizing it to make sure that AYAs can stay connected to their social relationships, especially during their cancer journey. But we really have to be mindful about its impact and how we're using it. So when I think about supporting your mental health and body image, there's a few tips that I have for you, really. And the first is be mindful of your digital footprint. Your online actions really leave a permanent trail, even if you delete it. Your friends, recruiters, colleges, everybody can see what you do. So really think about what you're posting and create real and authentic things that are central to your values as an individual. The second biggest thing I would say is don't compare yourself to others. Really curate your feed by unfollowing negative accounts and focus on your own progress and your own gratitude. Um, it's important to recognize that social media often shows these curated, highly realistic, unrealistic things that's not necessarily a person's full reality. And instead of comparing yourself, try to find inspiration in what you admire or simply practice gratitude in your own life and kind of make sure that you unsubscribe for things that don't serve you. Turn off the autoplay, follow the uplifting accounts, and unfollow the accounts that don't make you feel good about yourself. Really just eliminate the toxic content that you don't need to see. Um, and make sure you're setting a timer to not doom scroll. So take screen breaks, step away, and try to maintain that healthy balance between utilizing your phone for connection and also making sure that you're not getting sucked in too much. And then finally, I always talk about sleep hygiene with my AYAs and make sure you're creating a phone-free space. This means taking all of your devices and charging them outside of your room, and setting about a 60-minute screen-free period before bed. Okay, so we spent some time validating and naming the challenges of body image. So we're going to switch our focus to kind of talking about action. What actionable things can we do? And this kind of section is about building your toolkit. Body image recovery is not a single event. It is a process and starts with small daily changes. And we're going to talk about this from three angles. We're going to talk about our mindset, our actions, and then our relationships. So we're going to start really by talking about the hardest work, which is the mental work. You can change your thoughts, and that can also change your feelings. So the first thing I want to say is we need to give ourselves some self-compassion. And this is really the foundation. We are often much kinder to other individuals than we are ourselves. So if your friend said, my sports car is ugly, I hate my body, what would you be saying to them? You might say something along the lines of, this scar showed that you survived, and I love that you're still here and able to be my friend. So what you would say to somebody else is what you should be saying to yourself as well. So self-compassion really is simply applying the same grace and kindness that you would to other individuals or your family or your peers and apply it to your own inner monologue. When you have a negative thought, try to pause and think about this friend test. What would you say instead? And I like this picture because it really kind of takes how you could reframe those thoughts and reframe the narrative in a way. Really, it's about shifting from the damage and betrayal and kind of negative thoughts into one of resilience. Your body isn't a testament to what failed, it's a record of your survival. Every scar, device, change is proof that you fought a very hard fight. And instead of focusing on what your body can't do, focus on what it can do right now, today. And then we have to think about cognitive distancing. So this is a technique where you separate yourself from your negative thoughts. So when a thought pops up in the sense of, I look awful, don't always think that's the truth. There's a lot of false media out there and false content and things. You can also say false things about yourself. You should be trying to say things like, I have a thought that I look awful. And that's okay. Just by adding those first few words, it creates distance between what you might be feeling and making it say, I have a thought I feel that way. And it's not an absolute reality when you add those few words. It then is, you can kind of choose whether you want to engage with that. And then there's other actions that you can do that can help really immediately impact your mood. First of all, mindful movement is very important. Reclaiming physical activity is not just a punishment about your change in size or anything like that. It's really a celebration of how your body can still function. So you want to find an activity that makes you feel strong and capable and calm. So even if it's just a 15-minute walk per day, that's a goal that your body can accomplish. And it doesn't matter how many calories you burn or how toned you look. It's just there to make you feel like I did some movement and I'm moving forward. Um, we can also think about clothing and style. Many of our AYAs kind of revert to these baggy clothes to kind of hide these body changes. But I often want to challenge you to dress for your expression and comfort. Often you can use your AY, your fashion to express your identity. So I often have a lot of my AYAs who are really worried about losing their hair during a cancer experience. And I say, well, now's the time to try anything you want to do. Do you want to shave your hair? Do you want to dye it purple? Do you want a mohawk? Do you want a perm? Do something fun with it that you would never do that expresses your identity. This also could be trying bold jewelry, wearing different colors that just make you feel happy, and investing in clothes that maybe might fit a new shape better than one trying to fit into older clothes. Really, it's about stop dressing to conceal and start dressing to express. And then I already talked a lot about this already, but make sure you are doing the social media detox, really. We know that there are comparisons between things, especially between unrealistic beauty standards and things like that. And even comparisons between survivor stories if you're following different AYA accounts. You really just want to make sure that whatever you're viewing and experiencing there is something that you feel will serve you in your authenticity and or will make you happier at the end of the day. And then the hardest part about body image for many is kind of sharing this challenge and your feelings about all of this with others navigating intimacy. I know that Lauren is going to go into a lot more about that. But really, at the end of the day, it's just about communicating your feelings. The fear of rejection and judgment is very real. But the key really here is to be direct and honest with people you trust. If you are starting a new relationship, you control how you share your story. Um, a lot of my AYAs tend to wait till they have a stronger relationship to be able to share their experiences. And some of them who are more open with their experiences start from the beginning. And that just depends on who you are. But no matter what, open communication helps lower anxiety for everybody involved. And then I challenge you to do some gradual exposure. The more you avoid communicating about how you're feeling or communicate showing your body, like avoiding the mirror or avoiding going swimming, that's how the more powerful your anxiety becomes. We can't fit into this in baby steps. So if you're afraid to wear a new piece of clothing, you might want to wear it around your house first, or you might want to try a different errand. It's really about re-engaging slowly with this. And then focusing on connection. This is really about a shared experience. It's not about meeting a checklist or a standard. It's shifting the focus away from the physical and back into emotional safety and intimacy and connection. And this is really about being present and not necessarily about being perfect. And then sometimes the mental load is really heavy, so you need experts to help. So mental health professionals are incredibly important for the AYA experience, especially those that specialize in trauma, chronic illness, body image disorders. They have the tools and techniques that can help you do things like the cognitive distancing that we talked about, or the reframing the narrative. They can unpack complicated feelings about your body and or your cancer experience in a safe space. And it's not a sign of failure, it's about a sign of strength and self-awareness. And then there are many, many rehabilitation services that can help and support along the way. Really, the key takeaway from this that I want you to get is that I want you to ask your oncology team for referrals and or support because they are really an amazing starting point. And then the professional experience is not only essential, but it also is about finding your community, aka your tribe of people. We're going to share a lot of resources at the end of this, which there's some amazing AYA resources that we are shared throughout this whole experience. But get involved in support groups, get involved in online communities. There are so many AYA nonprofit organizations. Really, what I want you to get from this is that connection with others who have gone through similar experiences really is what helps you to combat any of the isolation and or feelings of anxiety, depression, loneliness that you might be experiencing. So we covered a lot today, and before Lauren moves on and kind of takes over, I kind of just want to leave you more with three simple tips, and we like to call them the three R's. This is just recognize that it's okay to feel conflicted about your body, and these feelings are normal. Reframe if you can, shift the focus from appearance and disability and or negative thoughts into resiliency and function slowly. It's not going to happen overnight. It's going to take slow steps along the way. And then reach out. You don't have to do this alone. There are many, many people around you who are willing to support you, whether your family, your peers, an oncology medical professional, a professional counselor, really finding people that will help you, empower you. It will make you feel better throughout this whole experience. And the process is about just rebuilding trust with your body through one small mindful step along the way. And now I'll turn it over to Lauren, who's going to do our talk on sexual impact.
Thank you, Kari. That was amazing. Absolutely full of incredible, incredible information. Thank you so much. You've set me up beautifully for the rest of this. If you don't mind hitting next for me, we're going to talk about sexual impacts and interventions for those impacts. Thank you. So, as Kari mentioned earlier on with that biopsychosocial model of sexual health, sexuality is a really complex human experience. It involves so many different pieces of who we are and our lives that exist around us. The ones that I really want to bring focus to and that we're actually going to talk more in depth about here is sexual function. That's that physical health part. We're going to talk about our emotional health. That's going to be really showing up more in the sexual desire and arousal space. And then our social health, our intimate relationships. Our sense of sexual self is not something we're going to dive deep into, but it's something I think is really important to highlight here, especially as AYAs. You may have had a really solid sense of who you were, and you may have been figuring that out, or kind of somewhere in the middle, right? And acknowledging that sense of self after a cancer diagnosis often shifts. And that's also true in the sexual space, in the sexuality space, is that your sense of sexual being, or it's called your sexual self schema, may also be shifting because of this cancer experience. And so, although we won't be diving into it, I really wanted to highlight this because all of these different components, and especially body image, as Kari just went over so beautifully with us, can really impact that sense of sexual being. Who am I as a sexual person in regards to how my body works, how I feel within my body, or how I feel about how my body looks, how my sexual being interacts within intimate relationships, and how I interact within myself and my own sexual relationship with myself, with desire, arousal, etc. Next slide, please. Thanks. So we're going to start with sexual function, or the physical part of sexuality. And we're going to talk about it in three different components. We're going to talk about it with those who have vaginas, vulvas, and clitorises. We're going to talk about with people who have penises and testes. And then we're going to talk about it with everybody, regardless of gender or genitals. These are things that anybody can experience. And I do want to highlight, as you've probably already noticed, I'm going to use pretty honest language when it comes to our bodies and our experiences. And so know that if talking about genitals, if talking about certain body parts or experiences is difficult for you, if you need to take a break, I just want to give you permission right here and right now. Feel free to take a step away, take a break, do whatever you need to do, because this can be hard conversations. Sometimes these words can be a little upsetting or a little hard to hear. And so I just want to acknowledge that for whoever's in the room with us today or watching this recording, that if you need to take a break, it's okay to take a break. So for our vulva, vagina, and clitoris owners, one of the biggest sexual function experiences is menopausal symptoms as a young person. And this isn't just because of hormonal therapies. This almost any therapy can impact these menopausal or genital symptoms of menopause. Genital urinary symptoms is what it's called. And so this can be things like vaginal dryness or atrophy. So these tissues are usually pretty plump and pretty moist. They can become fairly dry. Atrophy means that they're able to tear pretty easily. When they're moist and plump, like what we're used to, they're flexible. When they dry up or we experience menopause, they're not so flexible. And so when we're trying to stretch them, they have a more possibility of tearing. Tearing is going to be like micro tears, not usually like major tears, but those micro tears can be painful. We also might experience constriction or that lack of flexibility or tightening of the vaginal canal. We can also experience dyspareunia, which is pain with penetration. We can also experience outside of the genital function, hot flashes, sleep disturbances, mood changes, so on and so forth. And being a young person experiencing menopausal symptoms can be a pretty distressing and stark experience, right? As a young person, you haven't gotten the chance to experience perimenopause and menopause. You haven't walked into this pool of menopause from the shallow end. You dove in head first. And that's a hugely different experience than going through menopause as your body kind of naturally brought you there. So this medically induced menopause can be pretty intense. The other thing I want to experience outside of menopausal symptoms is this idea or experience of vaginal shortening. And we can particularly through radiation and surgeries, but literally the shortening or the shrinking of the vaginal canal. With those who have penises and testes, we may experience things like erectile dysfunction. And so this might be that erections are not as firm as they once were. We might have difficulty getting erections or maintaining erections. We might have changes in ejaculation. So this can be reduced ejaculate, how much ejaculate you have when you orgasm. This might be no ejaculate at all, which can be pretty distressing if you're used to having ejaculate come out with an orgasm, and now it's what's called a dry ejaculation, or there isn't anything there. That can be a big change to adjust to. We can also have something called retrograde ejaculation, which is when the ejaculate, instead of coming out the head of the penis, it actually comes out a little and then actually goes back into the body, which is one way we can experience a dry ejaculate. We might experience some pain with ejaculation and climax. And all of that can be a huge shift for a young person to experience in the way that they maybe have experienced their body previously. Additionally, regardless of genitals and regardless of gender, some of the things that people can experience additionally to this are sensation changes. So the intensity of the pleasurable sensation or the sensation at all. Sometimes things that once were pleasurable are now painful or uncomfortable. Orgasm can change, whether it's we don't achieve an orgasm, orgasms are less intense or they're harder to get. We might experience fatigue and sleep issues. And when we're really tired, we often don't have the energy or motivation to engage in sexual experiences. We might be experiencing non-genital and unwanted pain. So maybe that is from a surgery or from radiation. Maybe we are having some phantom pain with a limb change. Any type of unwanted pain usually pulls us away from a pleasurable sexual experience. or can even inhibit the interest or pleasure within a sexual experience. Maybe we're experiencing nausea. There's lots of things that cancer treatments and post-treatment experiences can bring that can interrupt or change the way that we experience sexual functioning. There's physical parts of sexuality throughout and beyond this experience. Next slide, please. I want to highlight a few things here, the sexual practices while in treatment and what the literature says. So I'm going to start with the yellow box. Is sex safe? Yes. Sexual activity during treatment generally is considered safe. We want you to have pleasurable sexual experiences. We don't want to halt your sex life. If we can avoid that from happening, we want to give you that permission. I'm going to go back up to the circle here. The challenge was really no evidence-based or established guidelines around sex practices or safer sex practices during therapy beyond contraception. And so when we're talking about safer sex, the literature gives us contraception, but we know safer sex involves a whole lot more than contraception. And so just want to highlight that challenge here. Exposure to chemotherapy. Those chemos and immunotherapies, they can be found in bodily fluids, thinking things like our ejaculate or our vaginal fluids in particular. The best way to stay safe is the use of a barrier. So this can be a condom, this can be a dental dam, some type of, well, those really are the main types of barriers that we're gonna utilize in a sexual experience, and abstaining from sexual activity for 48 to 72 hours after receiving the medication. So we're not asking you to abstain for the entirety of your treatment. We're saying in that short-term period immediately post receiving treatment, and then let's say you get treatment every 3 weeks, then you can engage in that sexual experience beyond that. If you get it every week, you have half a week, you can experience that if you choose to. Infections and the count debate. So my dear friend Kari might be able to speak a lot more to this as a medical provider, but highlighting that there are some concerns about increasing the risk of infection due to blood counts while in therapy because you're more immunocompromised. There's no evidence-based data to support specific blood count settings, but it's most important to really focus on the risk factors with sexual activity when your counts are low, right? So if somebody is sick that you engage with sexually and your counts are low or you're in treatment, maybe we wait for them to get healthier. If you're engaging in sexual activity with someone new, right? If your counts are low, maybe we wait a little bit while your counts get up, or we engage in sexual activity that might not put us at high of risk, right? There's a risk benefit analysis for you to do here. And then contraception. Cancer treatment can interfere with contraception, and some contraceptions you are automatically going to be taken off depending on the type of cancer you're on. For, hormone contraceptions, for example, contraceptions can even exacerbate some side effects. So it's really important to have accurate and timely discussions with your oncology providers about the contraception that is right for you in making sure that we're utilizing that. And oftentimes we are recommending 2 contraceptives, so like a barrier plus, right? And so having that conversation with your oncology providers about what 2 types of contraception, and we're not just talking about pregnancy reduction, right? It doesn't matter what gender of partner you are engaging with or whether or not pregnancy is a possibility. We're also talking about STIs and keeping you healthy and safe. And so still 2 types of barriers or contraceptives are recommended. Next slide. So we're going to talk about our interventions for function, this physical part of sexuality. So for our vagina owners, let's cleanse. Cleansing is warm water cleansing. You don't need to use douches. You don't need to use exfoliating soaps or anything like that. The vagina is a self-cleansing machine. So warm water on the vulva is generally enough. And then patting that or allowing that to air dry, utilizing cotton underwear when comfortable or when able, and no underwear at night if possible, because that reduces constriction and allows for free blood flow to the genital tissues. We want to moisturize with non-hormonal moisturizers. That's what the specific one is about. We're going to talk about hormones here in a minute. But non-hormonal moisturizers, we've got things that we engage with to help keep the moisture in the vaginal tissues. And so this is not only for people who are receiving hormone therapy that can really suck the moisture out of the tissues, but even those in chemotherapies, those who have had surgeries to the pelvic area, those who have received radiation to the pelvic area. This is a really important part of your just general vulvovaginal health. And then lubricate with sexual activity. Moisturizers and lubricants are different. There are some moisturizers that are a moisturizer lube combo. You're welcome to use those if you'd like. Those that I have worked with find that those tend to be a little bit more what is described as goopy on the moisturizer side of things, and can be a little less comfortable on the moisturizer side of things, but you're of course able to use those. Dilators, wands, Kegels, etc. Dilators are used to help very gently stretch the vaginal tissues, excuse me. So as we may experience some constriction or atrophy in those vaginal tissues, this is used to gently stretch them so that if we're engaging in any type of penetrative activity for sex, or we're engaging in, let's say, like a pelvic exam where that penetration is required, right? That we are experiencing some gentle exposure and stretch to allow that to occur in a more comfortable way. Help with pressure points if there's some sensitivity, especially the opening of the vagina, that can be a hard spot to reach with a dilator. So using a wand to gently stretch or touch to help reduce some of that pain, or reduce anxiety around touch. And then Kegels are particularly helpful for strengthening those muscles if we're having any incontinence. Generally, when I'm recommending these, I might provide general education, but I almost always recommend a referral to a pelvic floor physical therapist, PFPT, the first one on that professional support list. Pelvic floor physical therapists are physical therapists who specialize in the muscles of the pelvis, and they are incredible professionals to work with. Hormone therapy, or HRT, there are two different types. There's hormone therapy that is local, and there's hormone therapy that is systemic. Local is going to be things like creams that you put in and around the vagina or the vulva. And then systemic is going to be like a pill that goes through your whole body. Local literally stays local to those tissues. Systemic is something that you experience your whole body. There is more and more research coming out around hormone replacement therapies for people who have experienced cancer, and generally is becoming more recommended, especially with local therapies, even for those who have had a hormone positive breast cancer, for example. Would really encourage you to talk to your provider about hormone replacement therapy and just get some more conversation going around this, that you know whether this is an option for you. There are also medications out there to support vaginal dryness. That is I'm losing my words for a moment. I have it written down here just in case I would do that. There's also some moisturizers, medications for desire that can be used for vagina owners. And the one that's more recommended tends to be called Velisi. Again, something you need to talk to your provider about, but just know that those exist. Some of the ones you can do without a medical provider are going to be things like relaxation exercises. For vulvovaginal owners, when we're stressed or have anxiety, we tighten our vulvovaginal muscles. We might not know it, but we do. And so if we're having difficulty with a penetrative activity that we're interested in, and we're really tense or stressed or anxious, it might be even harder or more painful. So when we engage in those relaxation exercises for our body and our mind, sometimes it allows us to reduce some of the tension that's here to have a more pleasurable experience. Prolonging foreplay. Many of us after cancer, in this menopausal state or just changed body state, may just need more time to experience pleasure, more time to rev up, to warm up. And so prolonging that foreplay can be really helpful. And then exploring non-penetrative sexual activity. If penetrative sexual activity was part of your sexual script before, a sexual menu before, exploring the ones that are not penetrative can be really helpful in continuing a pleasurable sex life while not engaging in something that's either not possible or painful for you in the moment. For our penis owners, exploring medications like PDE5Is, those are going to be things like our Cialis or our Viagra, things like that. There are also pellets and gels you can insert into the tip of the penis, as well as injections you can do into the side of the penis that help with erections. There's the vacuum devices that basically they suck blood, they go around the penis, they suck blood into the penis, and then they put a constriction ring or what's kind of like a medicalized rubber band at the base of the penis to keep blood in there to allow for an erection to occur. They do tend to feel different. Sometimes they're purple or cold. Maybe they point down instead of up, just something to be aware of. There might take some emotional getting used to as well as physical getting used to, but they can allow for erections. Constriction rings are helpful for those that have difficulty maintaining an erection. So that constriction ring, again, once the erection arrives, we put the constriction ring at the base of the penis that allows that blood to stay there. For vacuum devices that use constriction rings or constriction rings on their own, really important to note, don't keep it on for more than 30 minutes. Otherwise, we're starting to get into a trouble zone just for like blood flow and health of the penis. So make sure it's not on for longer than 30 minutes. Implants are surgically placed, really kind of like a last minute, or not last minute, a last effort on the list. If we really can't engage our penis in erection, and that's really important to us, we can always explore the surgical option. Excuse me. The start stop method is something you can do on your own. It is masturbation involved. So keeping in mind that if that is comfortable to you, this might be a resource that's helpful to you. Basically starting the masturbation to getting aroused, stopping and allowing the erection to fall, re-engaging the penis with masturbation, allowing arousal to build again, letting it fall, kind of back and forth a few times, and then allowing yourself to climax. Basically, what this is doing is teaching your body and your mind that if you have difficulty maintaining an erection, pleasure and sexual activity can continue. For many people, losing an erection feels like the sexual activity has to end there. Knowing that it doesn't and giving yourself an exercise to engage that can be really helpful. And then non-penetrative sexual activity again. Professional support, pelvic floor physical therapists, our gynecologists, urologists, and andrologists. All of these specialize in various genitals and genital functioning and sexual functioning. So finding a medical provider if you need some evaluation done. Sex counselors are medical providers who are specialized in counseling around sexual issues, and sex therapists are mental health providers who are specialized in providing therapy around sexual concerns. And then addressing some of those physical, those non-genital, non-sexual, but physical symptoms that impact sexuality will be things like engaging in sexual activity at times where your fatigue or your nausea or your pain are not at peak. Taking medications for pain as prescribed, maybe about 30 minutes before sexual activity begins. Scheduling intimacy at times that you're more likely to feel well. And we'll talk about scheduling in a minute here. And there's many more, but some of these things might help address some of those physical issues. Taking rest. If you know you're going to have sex tonight and you're able to take a nap, get some rest, things like that, that will help your body prepare for that sexual activity. Next slide, please. I'm not going to really go into depth on this, but want you to have this chart on interventions for safer sex. This is really about those ANC and platelet counts, some things to consider with those counts, with the various forms of sexual activity, from kissing to different types of penetration. So again, not going to go into depth on this, but want you to have this to be able to refer back to. Next slide, please. Oh, Kari,
I'm just going to chime in really quickly too here and just say, talk to your healthcare provider about when it is safe for you. All of them are going to have their own personal opinions on this, but this is just a general guideline that myself as an oncology provider has kind of established, and one that I like to utilize for my patients who still want to have a healthy sex life while going through therapy.
Thanks, Kari. So now we're going to talk about sexual desire. And sexual desire is one of the most common things that I hear from my young my AYAs in general that are going through cancer, and their shift in their sexual experience is through sexual desire. And often will tell me that they just don't have sexual desire anymore, or that they feel broken because it doesn't work, things like that. And so I want to address this with a couple of models that can help you reframe or relearn your body, now that it's been through something like cancer. So responsive desire, many of us experience sexual desire, and sexual desire is what lives in your mind, what tells you that you're interested or that you want sex. Sexual arousal lives in your body. I just want to highlight that as we go through here. So the sexual desire piece, many of us will experience it, what I say, spontaneously. I like to joke, if the wind blows the right way, right, we're turned on, we're excited, we're ready to go. And that shifts a lot after going through cancer. Your body has changed, your mind has changed, the way you experience sex has changed. And so we start here with this emotional intimacy piece at the top, and that can be with yourself or with others. And emotional intimacy, along with to the right-hand side, seeking out and being willing or receptive to the possibility of experiencing interest, desire, or pleasure. If you've ever had a sexual encounter that you did for your partner, consensually for your partner, and you were like, this is for you, not for me. Let's get this over with, which a lot of people have experienced. And that's totally normal and absolutely okay to experience. But if you're wanting to experience pleasure, that mindset is not helping. And so we want to shift that mindset in the moments that we want to experience pleasure to being open to the possibility of experiencing it for you. And so once we have that openness and willingness and that emotional intimacy, sometimes that will click for sexual desire to kick in. A lot of the times after cancer, that's not enough anymore. So we need sexual stimuli. And sexual stimuli can be a huge range of things. One end, it can be, let's say you have a partner who is working from home or studying from home, and they're on a virtual meeting of some sort, and they are like owning their stuff. And that's really a huge turn on for you. That intellectual part of themselves has zero to do with sex, but it's a sexual stimuli for you. Let's go to the other end of the spectrum and talk about watching like really intensive porn, right? And that has literally everything to do with sex. And your sexual stimuli can lie anywhere on that spectrum. For some people, that's enough. And for some, it's not. And this is where those biological and psychological things come into play. Biological are going to be things like hormone therapy, chemotherapy, fatigue, nausea, pain, etc. Psychological are going to be things like anxiety, depression, fear, so on, like social engagement with a partner, so on and so forth, or with yourself, right? These things can inhibit the experience or the ability to experience pleasure, or not pleasure, excuse me, desire, at this stage in this model. So then we turn to sexual arousal. And sexual arousal can be such an important and such a difficult place to experience sexual desire, right? If you're not interested, why would you engage your body in sexual arousal? It's a really challenging hump to get over. I just want to acknowledge that. But if we can allow our bodies to experience sexual arousal with yourself or with others in a consensual and safe way, sometimes when the body kicks in, then the mind kicks in. We experience both together and experience physical satisfaction and emotional satisfaction. So that's a responsive desire model, basically saying your desire can respond to things. Dual control model says that everybody has gas and brake pedals of sexual desire. So your gas are your turn-ons, your brakes are your turn-offs, or your motivators and your barriers. One of the biggest barriers or brakes is stress and anxiety. So obviously something that we know many AYAs experience in the cancer space is stress and anxiety, right? So we might be experiencing some of those brake pedal pushers. One of the things, a couple of things to know. What are your brake pedal pushers? What are your gas pedal pushers, right? Knowing what's on your individual list, because this is different for everybody. And then knowing, is anything touching my brakes? Because if my brakes are on or they're potentially to the floor, if you've ever gotten in a car, push your brake to the floor and then tried to hit your gas, not really going anywhere or not going anywhere fast. Same thing here. We want to release that brake as much as we can before we're pushing the gas to really get the most benefit out of those motivators. Next slide, please. I also want to note that some of the cancer-related factors that can contribute to some of these body image experience or some of these desire experiences are changes in body image, as Kari went over with us, that self-schema or who you feel like as a sexual being or learning who you are as a person in general now, relationship dynamics, physical well-being, again, that nausea, that fatigue, etc., changes in the function and mental health. And there are some psychological consequences of low sexual desire that can be increased distress or anxiety. Some depression can increase because of reduced sexual desire. There's some body image changes or self-esteem changes that can come from reduced sexual desire, some reduced intimacy within relationships, etc. So some of the things that you can do when you're experiencing lowered sexual desire or lowered sexual arousal is foreplay of the mind. Foreplay of the mind basically says desire is in your brain, right? Sex starts in your brain. And so if we want to experience sexual pleasure or sexual desire, we need to start with our mindset, right? Getting yourself into the space where you want to experience and reminding yourself that you want to experience this. It can be hard and challenging to do. Sometimes a therapist is a really helpful place to start to explore that. But reclaiming that desire in your mind, reclaiming that interest that at least I want to want sex, right? And that counts as interest. And expanding your view of foreplay, right? Oftentimes we talk about foreplay in the physical space. Let's talk about foreplay in the mental space. We can utilize things like senses and exploring your senses through touch, smell, taste, etc. on your own for foreplay. We'll talk about exploring your senses in a sexual way within an activity in a moment, but also thinking about, maybe sexting or leaving fun notes around the house for yourself or for someone else, scheduling something that you know that it's coming, giving your mind the chance to warm up. Foreplay is your body warming up. Let's give your mind the chance to warm up. Learn your own desires. Ask yourself, what turns me on? What turns me off? Or what do I do that turns me on or turns me off? What does my partner or partners do that turn me on and turn me off? Another way to ask, if that's a hard question to answer, is what are my brakes and accelerators, right? Giving yourself the chance to make those lists and understand what gets you going and what kind of stands in the way. Practicing pleasure, and this is particularly through masturbation. And I want to note, not everybody is comfortable with that, and that's absolutely okay. If masturbation falls within your comfort and your morals and your values for your life, exploring your body through masturbation, through sensual touch on your own can be really helpful because many people experience those shifts in sensation or pleasure, and not knowing what is comfortable or pleasurable for you makes it hard to ask a partner what's comfortable and pleasurable during a sexual experience. So learning your body and understanding what feels good to you allows you to communicate that to partners or future partners. And then exploring, after that experience of self-touch, of how was that for me? How was that for my body? Did my body respond differently than what it has in the past? If I've experienced this in the past, did increasing my sense of physical pleasure or arousal increase my desire? How did it feel to experience desire after pleasure, if that's something that you experienced in that moment? Just kind of giving yourself a chance to reflect. And then exploring your senses during sexual activity or foreplay can be things like setting candles, putting music on, utilizing clothing that feels good, sexy, and comfortable to you, bringing in fantasies, bringing in, let's say you want to play with food, right? Bringing in things like that, keeping in that infection control thing in the back of your mind, but bringing in, right, some of the, maybe we're going to bring in strawberries or chocolate, some of the typicals, or we want to bring in flavored lube or something, some things to tantalize those sensations and those senses to engage your mind in desire or your body in arousal. Next slide, please. Intimate relationships. There's 3 different types of intimacy within relationships. This is emotional intimacy, that emotional closeness that you feel to somebody. Physical intimacy, that's going to be things like holding hands, cuddling, physical touch, hugs. Sometimes kisses can fall within here. And then there's sexual intimacy, and that can be things ranging from kisses to massage can kind of fall in both categories of physical and sexual. We can experience then oral sex, penetrative sex, etc. And so just knowing that those three types of sexual or those three types of intimacy exist. And for many people in intimate relationships, if one of the first two, emotional or physical, fall out, sexual starts to experience some challenges as well. If emotional intimacy falls out, for many people, the other two fall out as well. And so knowing that there is sometimes a cascading effect of strength or of challenge if we're experiencing strength or challenge within kind of the top tiers as we get down to sexual intimacy. Making space for grief, right? A lot has changed with cancer, with your body, with your sexual experiences, potentially within a relationship if you're currently in one. Giving yourself and your relationship, if you're in a relationship, the chance to grieve. I think Kari said this early on, is the space for grief. It's so important to acknowledge that there is grief involved here. And it's okay to grieve. It's okay to be angry. It's okay to be sad. It's okay to be frustrated, to be confused. It's okay to grieve. Give yourself the permission to grieve. Once we're able to process that grief and work through it, we're usually able to come to another side and start exploring. But if we're holding that grief and we're not acknowledging it, it tends to come with us. And so we really want to make that space. Understanding your definitions of sex and sexual intimacy. What does it mean to you? Sex is totally different to everybody. So for you, sex might mean anything from light kissing to rigorous sexual activity with penetration. It might mean massage is included, right? If a shirt is off, that counts as sex. Or it might only mean something like penetrative sex or oral sex, right? What's the definition for you? What's the definition for your partner or partners? Has that your experience of your definition of sex changed? Does your body experience it differently? Does your mind experience it differently? Does your relationship experience it differently? And does your definition need to change? Something to explore. Navigating established relationships comes with navigating transitions. We went from friends to lovers to patients and caregivers. And now maybe we're trying to go back to friends and lovers, or we're trying to still be friends and lovers while we're also feeling this patient caregiver dynamic. That can be really challenging. And we're also navigating emotional experiences of yourself, of your partner or partners, around cancer, around caregiving, around life, and around sexual intimacy. And then navigating new partnerships comes with challenges like there's just a lot of things to navigate in a new partnership, right? Who's this new person? How do I feel about them? My own emotions around dating after cancer. Potentially some fears or thoughts or concerns around when do I share about my cancer or do I talk about sex, etc. Next slide. Sorry, I know I'm going really fast. I'm trying to get us through to 7:30. So a few interventions for intimate relationships. We're going to break this up with established relationships and new relationships. So for our established relationships, we want to increase non-sexual intimacy where possible. So again, that's the emotional and physical intimacy is our non-sexual intimacy spaces. And when we increase those things, we increase closeness, we increase connection, we increase vulnerability. And that often leads us to a space where we can start to explore or increase sexual activity when we are ready, if it's something that we're having some challenges with. And so thinking about like what makes me feel connected to you or as my partner or partners, and doing this exercise with your partner or partners, giving yourselves a chance to have what can be sometimes connecting and fun and exploratory conversation around what makes me feel connected to you, what makes you feel connected to me, and how can we increase that within this relationship. And enhancing that through things like date nights, intellectual conversations, cuddling, kissing, whatever comes up on those lists, finding ways to bring that in. I know when I say that, it's hard to do. There's a lot going on in life. Maybe you're working, maybe you're going through cancer treatments in the moment. Maybe you're dealing with children or other schedules that are really challenging. So I know when I say this, it sounds kind of nonchalant. I know that it's not. It is very hard. So sometimes when you're figuring out how to increase this, scheduling it can be really helpful because it makes sure we're actually doing it. This also comes with sexual intimacy, right? Scheduling it, when we schedule things that are priorities to us, it can feel like the least sexy or intimate thing we can choose to do. And yet it can be really helpful in allowing us to get into a rhythm that feels good for the relationship. Communication is really important. Kari mentioned this earlier. Honest, direct communication is super important. And we also want to recognize that many of us are not taught how to talk about sex. Many of us are maybe even taught not to talk about sex. And so this can be a really challenging conversation. Starting with baby steps within the relationship can be really helpful. If this feels impossible to do on your own, one, no, you're not alone. This is really hard to do for a lot of relationships. Two, maybe seek out some support, right? Talk to friends if you feel comfortable having that conversation on how they navigate this in the relationship, or come to a therapist who knows about the experiences of cancer and intimate relationships and have them help you how to navigate these conversations. Rewrite your scripts. Everybody has a sexual script when it comes to sexual intimacy. It's usually like this happens, that happens, this happens, that happens, we orgasm, and things are done, right? The typical script of, and I don't give you like the actual definitions of what's in each space because everybody's script is different and unique to them and their relationships. But redefining and rewriting those scripts can sometimes be really helpful because things have changed. So sometimes our scripts need to change. And this is true throughout life, right? We might change the script right now, and then we'll need to change it again later at some point. Finding the right timing when you're not exhausted, when you're not stressed. This can be hard to do. This is why scheduling is super helpful. In particular, or really just intimate anything, right? Let's get the distractions out of the way. Let's make sure it's a time when our kids are occupied if we have them. These can be really hard spaces to find, which is why we schedule. And if we can get over the hump of scheduling is the least sexy thing on the planet and go back to scheduling means it's important to me. Scheduling means it's a priority. This is a priority for us. Scheduling, we can sometimes make it playful, like when we were dating or if we were dating pre-cancer and we were sexually active, we were scheduling sex and just like not calling it that. So like, can we start to be playful with the mindset of if we're dating and sexually active in the past, let's bring back this idea of being dating or being together, whether you're still dating or you're in a different part of your relationship, and bringing in that sexual curiosity and funness to scheduling when trying to fit this important piece of your relationship in. Focusing on pleasure, a lot of scripts around sexuality involve performance and outcome. Penetration, orgasm is typical, right? Let's take that out. Let's try and shift from our performance and outcome to a pleasure focus, right? Being together, being present, focusing on pleasure rather than focusing on what it's supposed to look like. And that can really free up the script, but it also can reduce some of the pressure. And include relaxation and mindfulness on your own or within your partnership if you're feeling some anxiety about engaging in sex after cancer. And that's very, very common to experience some of that anxiety. For new relationships, when to share about cancer is really up to you. Like Kari said, there are some that are going to get it right off the bat, and there are some that are going to wait. The typical tip, one, there's no right or wrong time. Two is going to be finding the time that makes sense for you, typically before there are love feelings or before sex. That's like the general guideline, because usually after there are love feelings, if this person does not respond well, there will be more heartbreak. And that's just kind of part of the experience, unfortunately. What we want to do is protect your heart a little bit. And so having that conversation prior to love feelings, when possible or when comfortable, or prior to sex, which can often lead to love feelings when possible or when comfortable. What to share is really up to you. Think, really give yourself the time to reflect about what is important to me to share with this new person about my experiences around cancer or my experiences around sex. The other piece about when and what to share is like, when would I share other important information and how would I share that about my life, right? Other really important or vulnerable or really personal big things in my life. How would I share that? When would I share that? And can this fit into a similar mold? And give yourself some time to reflect. Getting ready for those conversations, basically practicing. Practice in front of a mirror with a trusted person, a best friend, a loved one, a therapist. Writing can be really helpful. Thinking your mind can be really helpful, but it's different than saying the words physically. So really do encourage like physically saying the words out loud prior to doing that in the new relationship. Know your boundaries. There are going to be questions. I could almost guarantee it. There are going to be questions from the new partner. Giving yourself the chance to, one, expect those questions, and two, say, I'm not ready to talk about that, or I'm not really sure about that, or can I think about that and come back to it, right? Know your boundaries and give yourself permission to say, like, I know you're going to have questions. This is all I'm ready to share with you, but feel free to ask questions and I'll get back to them at another time. Give yourself the permission to set boundaries. And social. Kari did a beautiful and in-depth dive into social media. But basically, if you've posted about your cancer experience on social, there's a chance that your new date already knows about it, right? So just being aware of what's on social and your privacy around that, and that this person may have seen it already and they may not have. And so just being aware of that potential impact here. I think that's the last one. And I brought us pretty much to the end. There are some incredible AYA resources here, specific for support, both locally and nationally, as well as several like sexual health specific resources.
Wonderful.
Challenge room.
Go ahead.
There's just a lot. I mean, between Lauren and I, we could absolutely like shower you guys with so many amazing opportunities and resources and things that we've utilized over the years with our AYA patients. And obviously, we'll go to I'll kind of flip to here. Feel free to reach out to either of us with questions or concerns. I put my contact information. Lauren has her contact information. We're happy to share, but we'll kind of move to the question and answer portion.
Yeah. Thank you so much, Lauren and Kari. That was so great. We did get some questions. So one of the questions was, what are some tips for advocating for yourself during medical appointments about side effects related to sexual function, especially since the provider doesn't always bring it up themselves? So I think that question is,
Yeah.
you be the one to bring it up when it's not the doctor.
And
Yeah.
Lauren, I'll tell you, like from a provider perspective, that's something
Please.
like I always love to ask, especially during my survivorship clinic visits. I often take the time to pull my AYAs away from their parents, caregivers, spouses, partners, whoever is there with them, to just get to some nitty gritty and make sure because I realize that it is such a taboo topic and it's something that I'm passionate about sharing, but I know that's not every individual healthcare provider, and especially a lot of my peers are not the same way. So, what tips do you have, I guess?
Yeah, Kari, one, thank you for doing that. Like, that's amazing. I'm so grateful that you do that for the people you work with. And you're absolutely right. That is, I would argue that is not the common experience. And so some tips, if you feel comfortable enough with your doctor, I'd say just go out and ask. You know, if you feel like you can't quite be that blunt about it, say, I have some questions about my intimate life. Can we talk about that? Right? Give them the kind of like the intro if you're not ready to be like, my vagina is feeling pretty dry. What can I do about it? Right? Like if you're not ready to dive into that, giving kind of that leading question. If you're not quite as comfortable with your doctor, but there's somebody else on your healthcare team that you are, your social worker, your therapist, your navigator, your nurse, start with them, talk to them, and help them help you have that conversation with your medical provider. Something else that can also help, because this is a hard conversation to have, is write it down. When our adrenaline comes in because we're feeling nervous, we often forget what it is that we want to ask because our adrenaline is taking over our brain. So let's write down the questions that we have. You can even hand them to your doctor and say, I have these questions. Can we talk about it? And so if you're not ready to say, like, I need help with my erection, right? If you're not ready to say that out loud, but you really want the information, hand them the piece of paper in your conversation and say, I want to talk about this.
I'll chime in too. The My Chart and or whatever EMR system that you're utilizing, and it's an awesome opportunity too. That if you, even if you're not comfortable actually physically saying it out loud or talking to somebody, that message will get to your provider, and that will address your concerns. Usually, these are direct messaging systems, and sometimes it's easier to do it in a written space than it is to do it in actually in-person communication.
Absolutely.
Wonderful. Thank you. I think that, yeah, definitely covers that question of just finding different ways to communicate. The other question we got was, can some of these issues with sexual functioning and fertility arise years after treatment, or is it just during?
No, they can definitely arise years after treatment. For some people, they don't experience it until years after treatment, or let's say we're not engaging in sexual activity or not utilizing those various parts of our bodies in the way that we might in a sexual experience. And so maybe it was affected and we didn't know it. And so we're experiencing it years later, or sometimes it could just flat out show up years later. So knowing that, yes, that is absolutely, unfortunately, it is a possibility, but it's also like a common and normal possibility. So if that's experiencing to you or your body, you're not alone in that. You're not abnormal. Your body isn't doing something it's not supposed to. But unfortunately, this sometimes can happen with treatments. And
Yeah, and I'll
Kari,
chime
yeah,
in,
as a
yeah, and say that it is not uncommon to have late effects of treatment, especially depending on different types of therapy that you received. So if you were younger when you were diagnosed and maybe fertility and or other issues were not necessarily addressed, and now we're later in life and there are a different time period, we can start to see a lot of these changes. And your medical team should be monitoring you for these late effects of treatment once you are off therapy, usually in the form of survivorship clinics. But some of the things that I often see are premature ovarian insufficiency or early menopause can be a common side effect from some very specific chemotherapies as well as radiation treatment and or premature testicular failure as well. And these are things like you might not expect to experience menopause till you're in your late 40s, 50s, but a lot of our AYA sometimes, if they were treated with different therapies at younger ages, they're actually experiencing this way early. So more or less in their late 20s or 30s, sometimes they may be experiencing some of these early menopausal symptoms or early testicular failure experiences, which is very different from your peers. So yeah, unfortunately, it can be a throughout treatment type of thing for these sexual health and body image concerns.
Okay. Thank you. That's all the questions we have for right now. I know we're a little past time, so it might be time for us to wrap up this wonderful presentation. For those watching and for those watching this recording, of course, if it'll be available on demand, so all those great resources will be able to at least be viewed. And then anyone that's been registered for this presentation or series will receive the slides and we'll have all those great resources there. But on behalf of our ANOVA AYA program and the AYA Talk series, I just want to give a big thank you to Kari and Lauren for joining us today. This was such a great presentation and something that is so important.
Thank you for
thank
having
you.
us.
All right.